The information shared on the Sky Women's Health podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding your medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. Reliance on any information provided by Sky Women's Health, Dr. Carolyn Moyers, or any guests featured on the podcast is solely at your own risk.
You're listening to Sky Women's Health Podcast, your evidence-based resource for women's health and wellness, exploring the holistic principles of osteopathy, integrating mind, body, and spirit, designed to empower you as your own healthcare advocate and help you live your best life. I'm your host, board-certified OBGYN, Dr. Carolyn Moyers.
Welcome back to Sky Women's Health Podcast. Today we're talking about a pilot study, not a randomized controlled trial, but a small retrospective chart review that raises a genuinely important clinical question about why some women with recurrent UTI symptoms, persistently negative urine cultures, and symptoms that won't resolve despite appropriate antibiotic treatment may actually be dealing with something else entirely. That something else, hormonally mediated vestibulodynia, a condition driven by estrogen and androgen deficiency in the vulvar vestibule, and one that shares the same tissue origin, the same receptor profile, and the same biologic story as what we call genitourinary syndrome of menopause, or GSM. I treat these all the time in my office, and so I'm excited to share this with you. This episode is also a direct companion to episode 149, way back when. I interviewed Dr. Jill Kraft, and the title is When Sex Hurts, and we will link the show notes for that one. If you've not listened to it, I'd encourage you to go back and take a listen, because what Dr. Kraft laid out about vestibulodynia is the biologic foundation for everything that we're going to discuss today. The anatomy, the hormonal mechanism, the receptor biology, it's all there. Today, we're extending that conversation into the bladder. In episode 149, Dr. Jill Kraft, a vulvar-vaginal specialist and one of the leading clinical voices for vestibulodynia in this country, and the one I always go to for a second opinion, walked us through what actually causes pain at the vaginal opening. And the core of her explanation was hormonal, specifically androgen deficiency. Low testosterone at this tissue level of the vestibule creates a chronic inflammatory state. The tissue changes, pain receptors become sensitized, sex becomes painful. But here's the piece that I want you to hold on to. The vulvar vestibule, the opening of the vagina, that small almond-shaped, about the size of a postage stamp area of tissue just below the clitoris, around to the posterior fourchette, that tissue right from the labia minora into the vagina, that transition zone. That and the urethra share common embryologic origin. They develop from the same tissue. So when you have hormonal deficiency, that is driving inflammation and tissue dysregulation in the vestibule. The same process is affecting the urethra. And the urethra connects to the bladder. The bladder trigone, the base of the bladder, which is also rich in estrogen and androgen receptors, same embryologic origin, same receptor profile, same vulnerability to hormonal disruption. And when we recorded episode 149, we were talking about why sex hurts. What this new research is showing us is that we were also, without explicitly saying so, talking about why the bladder can be affected by some hormonal deficiency, or by the same hormonal deficiency. The vestibule and the bladder are not two separate clinical problems. They are one system. So let's talk about this study. It was published in 2026 in the Journal of Sexual Medicine, the association between hormonally mediated vestibulodynia and persistent urogenital symptoms, a retrospective chart review. The lead corresponding author is Dr. Maria Uloco, a urologist and sexual medicine specialist at UC San Diego. The researchers did a retrospective chart review, meaning they looked back at patients' records from a specialty vulvar and recurrent UTI clinic. And this included 253 patients with the average age of 53 who had all been diagnosed with recurrent urinary tract infections and who had persistent urogenital symptoms, urinary urgency, frequency, pelvic pain, pain when they urinated, despite 2 or more negative urine cultures. These are the women who were told over and over, your culture is negative, you don't have an infection, but they were still symptomatic. And this is exactly the puzzle this study is trying to solve. So here's what they found. 85% of these women, 85% had clinical findings consistent with hormonally mediated vestibulodynia, not a bladder problem, a vestibule and hormone problem. And 75% had pelvic floor hypertonicity, meaning their pelvic floor muscles were tight. They were in this chronically tightened, guarded state. And this is the finding that I think is most underappreciated. Only 15% of the cohort actually had findings that could be attributed to a classic urologic cause, meaning it wasn't actually the bladder. For most patients, only 15%. So that means that 85% of these women who had been cycling through antibiotics, clinic visits, repeat cultures, have a condition that is hormonal and vulvovaginal in origin, not urologic. And that's not a minor clinical footnote. This is a complete reframe for how we should be approaching this symptom pattern. They also did hormone testing on the premenopausal and perimenopausal patients. So this was 93 women, because remember, the average age was 53. The average age of menopause is 51. So 45 to 55 could be going through menopause, being defined as 12 months without a cycle. Prior to that, it's perimenopause. So in these people, they looked at their testosterone levels, and 98.9% had free testosterone levels that were below the normal female physiologic range. So they were androgen deficient. And remember, these were not all postmenopausal women. There were premenopausal women too, which tells us something really important. This is not just a menopause story. Androgen deficiency and the vestibular and bladder symptoms that come with it can happen at any age. Let me walk you through the pathway the researchers propose, because it is elegant and finally explains what so many women have been experiencing. So step 1, hormonal disruption. Something, whether that's menopause, perimenopause, postpartum hormonal shifts, low-dose oral contraceptive pills, or just individual variation, causes a drop in estrogen and androgens, or both. Step 2, the vestibule becomes inflamed because it is exquisitely sensitive to hormones. That deficiency triggers a chronic inflammatory state. The tissue environment changes. The local microbiome shifts. Pain receptors in the vestibule get upregulated. Step 3, the pelvic floor responds. When the vulvar tissues are inflamed and sensitive, the pelvic floor muscles become guarded. They tighten protectively. This is a normal neuromuscular response, but when it becomes chronic, you get pelvic floor hypertonicity. And hypertonic pelvic floor muscles can actually inhibit the detrusor, the muscle that contracts when your bladder needs to empty, which impairs normal bladder function. Step 4, the urethra and bladder trigone, which share the same embryologic origin and receptor profile as the vestibule, are simultaneously affected by the same hormonal deficiency. So you get urethral sensitivity and irritability, bladder urgency, frequency, discomfort that mimics a UTI. The result is this self-perpetuating cycle. Vestibular inflammation drives pelvic floor guarding worsens bladder function, the bladder symptoms feel like an infection, antibiotics are prescribed, they don't resolve the underlying hormonal driver, symptoms persist, and the whole cycle continues. Now, I want to connect this to a term you have heard before, especially if you've listened to this podcast, GSM, genitourinary syndrome of menopause. GSM is the umbrella diagnosis we use to describe the constellation of symptoms that come from estrogen and androgen loss in the urogenital systems during and after menopause. Vaginal dryness, tissue thinning and fragility, decreased lubrication, pain with sex, urinary urgency, urinary frequency, and recurrent infections, urinary tract infections. It is enormously common, but still underdiagnosed and undertreated. Nothing gets me more riled up than a postmenopausal woman who was given a testosterone pellet for her lack of sexual desire and painful sex. And when you do an exam, she has vaginal atrophy, vestibular pain, and she was never given any vaginal estrogen. We have to treat the GSM. But what this study is telling us is that GSM and hormonally mediated vestibulodynia are not two separate diagnoses happening to overlap. They are the same biologic process. The vestibule, the vagina, the urethra, the bladder base are all part of one hormone responsive unit. And when estrogen and androgens drop, the whole unit is affected. In a postmenopausal woman, we call it GSM. In a premenopausal woman with androgen deficiency, we call it hormonally mediated vestibulodynia. But the tissue level pathophysiology, chronic inflammation, microbiome disruption, pain receptor upregulation, tissue changes, it is identical. So the authors make exactly this argument. They propose that hormonally mediated vestibulodynia and GSM are not two distinct conditions. They are the same condition presenting differently depending on where you are in your reproductive life. The pathophysiology is identical, a symptomatic deficiency of estrogens, androgens, or both in hormone responsive urogenital tissues. So let's talk about implications for how we treat women, because if you know it's hormone deficiency problem, you treat the hormone deficiency, which is where I want to go next. So what does this mean if you are a woman sitting with chronic urinary symptoms and negative urine cultures? First, ask your doctor to look at the whole picture. A pelvic exam matters here. A vestibular assessment matters. A hormonal evaluation matters. If you're cycling through antibiotics for a UTI that never fully clears, the bladder may not be where the answer lies. And this requires a careful exam of the vulva, a palpation of the pelvic floor muscles, a Q-tip exam examining that vestibular region, and then a look at the vaginal walls and even palpating the uterus, the cervix, and ovaries. So looking at that whole picture to assess where is the pain actually. Second, if you also have pain with sex, dryness, or vestibular sensitivity, that is not a separate complaint to bury at the end of the appointment. That is clinically connected to your urinary symptoms. Put it on the table. Those are data points that help your doctor see the full picture. Third, pelvic floor physical therapy is not just for leakage. A pelvic floor therapist who works with hypertonic conditions, meaning muscles that are too tight rather than too weak, can be transformative for this symptom pattern. If your pelvic floor is guarded, treating the muscles is part of treating the bladder. I love pelvic floor physical therapy. I utilize it all the time. Pelvic floor physical therapy and vaginal estrogen are oftentimes key for starting therapy. Fourth, local hormone therapy is not just for sex. It is treatment for tissue level hormone deficiency that is driving your symptoms. For women with genitourinary syndrome of menopause, vaginal estrogen is the standard of care. Vaginal estrogen cream, vaginal estrogen tablets or suppositories, the vaginal ring, these are all local low systemic absorption treatments that restore estrogen to the tissue. They improve dryness, tissue integrity, the urethral lining, and bladder urgency. The study we discussed references data from another study showing that vaginal DHEA, prosterone, or interosa, a precursor that converts locally into both estrogen and androgens, was associated with significantly lower UTI prevalence in women with vulvovaginal atrophy. So, treating that hormone environment changed the infection pattern, or perhaps the perception of an infection, right? Because it could also be that their urine culture where it's negative. So here's what I want to add, because this is where the vestibulodynia piece matters specifically. Vaginal estrogen alone may not be enough for the vestibule. The vestibule is an androgen dominant tissue. There are more testosterone receptors in that lower portion of the vagina and the vestibule specifically. Estrogen receptors really matter here, but androgen receptors matter equally. And if the driver of vestibular inflammation and pain is an androgen deficiency, which the free testosterone data in the study strongly supports, then treating with estrogen alone is treating only half of the problem. So, oftentimes we'll start, if somebody has significant GSM, we'll start with vaginal estrogen. And if their pain is not resolved, add in a testosterone. For hormonally mediated vestibulodynia specifically, particularly when there is vestibular pain on exam, sensitivity, or dyspareunia alongside the urinary symptoms, the treatment approach I use is compounded topical preparation combining both estradiol and testosterone. Specifically, compounded estradiol 0.01% with testosterone 0.1% in a methylcellulose gel, applied directly to the introitus, rubbing it in. So it's applied to that vaginal opening twice weekly for 2 weeks and then once a day for 12 weeks. Why methylcellulose gel? It is a water based, non irritating base that is appropriate for sensitive vestibular tissue. The doses are low and applied locally, and this is not systemic hormone therapy, okay? This is not going to raise your blood levels. The goal is tissue level restoration of the estrogen and androgen milieu in the vestibule and the surrounding structures. So I want to be clear. These are not over the counter products. A compounded preparation requires a prescription and needs to be prepared by a compounding pharmacy. If you're seeing symptoms that fit this pattern, vestibular pain, pain with sex, dryness, plus a persistent urinary symptoms, bring it up with your doctor. Ask explicitly about whether local hormone therapy that addresses both estrogen and androgen is appropriate for you. This is what integrated care looks like, not just treating the symptoms in silos, not just rotating antibiotics, but understanding the biologic system and addressing the actual driver. Also, this is why I desperately want patients to come in and give me a urine sample before we start antibiotics so we can actually know what we're dealing with. And when in doubt, do a physical exam. Now, this study isn't the only piece of evidence pointing in this direction. I want to bring in a second study because together they look much stronger for this case. The one published in Menopause in 2025 by Rubin and colleagues that I mentioned earlier examined the prevalence of urinary tract infections in women with vulvovaginal atrophy. So the skin changes that we start to see to the vulva and the vagina, the same tissue level hormone deficiency condition we've been describing. And then looked at what happened to UTI rates when those women were treated with vaginal progesterone or interosa. This DHEA, a precursor hormone to the vaginal tissue, converts locally into both estrogen and androgens. It's FDA approved for intravaginal use, and it directly addresses both arms of the hormonal deficiency that we've been discussing. And what Rubin found, women with vulvovaginal atrophy had a significantly higher prevalence of UTIs, and treatment with vaginal interosa was associated with a meaningful lower rate of urinary tract infections. So treating the vulvovaginal hormone environment changes that urologic outcome, which I think I kind of outlined before, but just so that we are clear on that. So this matters because it provides biologic proof of concept. It's not just that these conditions correlate, it is addressing the same hormonal deficiency in tissues that appear to reduce the downstream urinary consequences. Looking at all that data, the picture becomes more coherent that hormone deficiency in the urogenital tissue creates a vulnerability to both vestibular inflammation and urinary symptoms, and treating that deficiency has downstream effects for both. So, before I close, I want to be direct with you about something. I've spent this episode walking you through what I think is genuinely important and promising research, but I would not be doing my job if I presented it without telling you exactly where the limitations are. Clinical research has nuance, and you deserve to understand it instead of seeing sound bites on social media that make you think that it's gospel and there's some new breakthrough study. Okay. This is this pilot study. It's retrospective. It's a chart review. That means the researchers looked back at existing patient records. They did not design a prospective trial where patients were followed forward with a clinical protocol. The limitations are selection bias. So, these were people who were coming to a specialty clinic looking at complex, often treatment resistant cases. And that might not be the same for the general population at a general gynecology or urology practice. The 85% finding for hormonally mediated vestibulodynia may be a real signal, but it may also be elevated because this group was pre-selected for its complexity. So just some things to keep in mind there. The hormonal evaluations were not uniform. Premenopausal and perimenopausal patients had hormone testing done, but the postmenopausal patients did not. third, there was no long-term outcome data, which is common for these retrospective reviews. So the diagnosis of hormonally mediated vestibulodynia was based on clinical assessment. There's no validated objective biomarkers for this diagnosis. So, what the researchers themselves call for, and I agree, is prospective controlled trials that standardize hormonal assessments that investigate whether a treatment approach targeting the underlying vulvovaginal and pelvic floor contributors can actually break that cycle of persistent symptoms and improve outcomes for women with recurrent UTIs. But we just don't have that research yet. So, this research is a signal, not a verdict. If you have this symptom pattern, it is absolutely worth bringing up with your doctor. I can tell you personally in my practice doing menopause and sexual medicine that I see this often where patients have urinary symptoms, a negative UTI, negative culture, and actually on exam have that positive Q-tip exam when looking at the vestibule. So antibiotics may not be appropriate in these cases, right? You have to look at what is their local hormone therapy. And for some of my patients, they're on both vaginal estrogen or a vaginal DHEA, but then they have that local estrogen testosterone compounded cream that they're applying to the vestibule specifically. And for many patients, it is life-changing. Pain-free sex, symptoms are gone. And then let's not forget pelvic floor physical therapy because it oftentimes does the body good. So if you have not listened to episode 149, When Sex Hurts with Dr. Jill Kraft, go back and take a listen alongside this episode. She is such a excellent educator, and she does such a good job of translating complex situations or difficult, complex patterns to the public. I really appreciate her advocacy and her education in this realm. So today we've looked at kind of the full picture of what this hormone responsive urogenital system is and why it matters. As always, if this resonated with you, share it with a woman who needs to hear it. Until next week, be well. Thanks for listening. This episode is sponsored by Sky Women's Health. If you love this episode, follow the show so you never miss one. Share it with the women in your life and help more people discover it. Let's make it binge-worthy.